Thank you, Dr. Dollahite. Very compelling talk. I'd like to first open it to the committee for questions. I, of course, have one, but I'd like you all to go first. Angela.
Thanks so much, Jamie, for an excellent talk. I had a question about your last slide because it pointed to, well, actually, I should say the slide about yes, but, because it made me think about some of the earlier things that you talked about, and often have this question with SNAP-Ed or with WIC, is this issue of dose, which becomes very challenging. And do you have any insights into, with some of the, what is the actual impact on dietary intake on some of the more community-based or practice-based interventions, probably compared to some of the more robust trials? Because initially you talked about like hospital visiting and things that were a little more robust, and I'm assuming in the original review that Contento did, all of that is sort of mixed together. And then later you presented more on the SNAP-Ed, which I'm assuming is more practice-based. So yes. If you could just give a little, talk a little bit about your insights into how those things compare. How much is the impact of the nutrition education in the community-based trial, community-based program?
Well, number one, I would say I think it varies by participant. I think there is an impact on some participants, not on others. It depends on where the participant is in their life at that time, as well as how the intervention is designed and delivered. I chose to focus as much as I did on the practice-based evidence because I think sometimes we look at well-designed randomized control trials and we say that intervention works. Yes, it worked under those circumstances and as delivered. However, it's not necessarily feasible in practice, and I think feasibility is a big deal here. So, does it impact intake in the long run? I have to believe that it does. I think the data support the fact that it does. I think you saw some prior to my talk today. There are all kinds of studies that continue to go on looking at that. The longitudinal data, particularly when it's collected through a phone survey and you get rid of at least some degree of social desirability, and you see some retention of behavior change, I do think so. Do I think that it's the level of change in dietary intake that we see in short-term trials? Probably not. But we also know in many studies of weight loss, for example, that in short-term trials we see an impact, but not long-term. And yet we have some longitudinal evidence that indicates some change. And so I have to rely on that. Thank you, Angela, for a challenging question.
I have a question.
Okay.
I feel like I'm crowding you out up here.
No, please. I'll step away.
I appreciated your thoughtful response because I think that is something that I personally grapple with. So I really enjoyed your slide that showed delivery of nutrition education across those three programs, because what you showed was about, I'm going to get the numbers wrong here, but about 2/3 of SNAP participants are getting nutrition education. The number for FNEP was 70-ish%, but the number for WIC was 100%.
Or food assistance.
For food assistance programs. I'm getting my slides confused.
They all got nutrition education.
They all got nutrition education. So here's sort of the dilemma within the WIC program is, while the RCT is the gold standard, when it's a required service, like it is in WIC, I can't randomly assign my participants to receive it or not. So it's harder to sort of achieve that standard of evidence when I'm within the WIC program. So I'm going to ask perhaps another hard question is, how do we get around that? So if the gold standard is the RCT, although the answer to your last question leads me to believe that many of us feel that there is still good evidence without RCTs, if the gold standard is an RCT, how could WIC get there, given that nutrition education is required?
So I just wrote a paper that was accepted, it's just been accepted, looking at different forms of evidence. And in it, I put that something along the lines of RCTs being the gold standard. And one of the people who reviewed it pre-publication said, I don't agree with that in these programs, that that's the gold standard. And I think where she was coming from, I didn't change it, but I think where she was coming from was that in practice there are so many different factors. So you're mentioning one, you can't tease it apart in WIC, which is why I wanted to talk about FNAP and SNAP-Ed, where we can tease it apart, right? And that one really nice study that looked at the differential impact with and without SNAP. But I think we have to, I think we need to test interventions in an RCT environment, but then I think they have to be delivered in practice, and that's what effectiveness trials are about, right? And with comparison groups, often not with true control groups. It's the only way we really can know what's happening, and then we have to do it the best we can and trust the data. That, it's all we can do.
Well, it looks like we're letting you off the hook now. Thank you. We really appreciate your time.